Hi, ladies and gentlemen, can you hear me and can you see me? If you can, please type in a yes in the comments section. We are live with Preregshorcuts. Today, we're going to be going through MHRA updates. We're looking at all the updates from January 2024 all the way to August 2025. So if you're excited to be here tonight, ladies and gents, please type in a yes. Let me make sure you can see me and let me make sure you can hear me too. This session is going to be extremely beneficial for anyone sitting the exam in November because the GPhC does test you on MHRA updates, on MHRA warnings. And if you're a pharmacist, you're also going to need to know this knowledge to stay up to date and a lot of important changes that have happened in the pharmacy recently. So again, if you can hear me, please type in the chat section. Just type in a yes, type in a hello. Let me make sure you can see me clearly. And let me make sure you can hear me clearly. I just want to take this opportunity, just thank all of you for joining in. Blessed Edohen, thank you for typing a yes. Great to have you on. Pharmacist, great to have you on. Eva Nagi, great to have you on as well. Paul Donor, Kana, give me a boom. Yes, that's a massive, massive boom. So for today's session, we're going to go through all the MHRA updates that have happened this year from January. And I'm also going to go through some important areas that get tested in the GPhC exam so that at least you're up to date and you're clued on so that if this comes up in the exam, you will smash it. So are we ready? Are we ready to go? So let's start with the first update. I'm going to go month by month, make it easy. Ali, hi Marvin, I hope you're okay. I heard the exam's already written 6 months before its date. So will this MHRA updates will be included in the exam? Yes, so obviously you need to learn all your updates. Now, don't fall for this. Yes, the GPhC does the exam early on. That's already been written. But remember, it's an online exam. Anything can change, okay? And also, some of these updates have just been, they've been going on for a while, okay? So although, and you're going to see that later on, although you may have a recent update, there are also some other things I'm going to talk about that happened last year. So it's like a continuation, right? So most of the time they're going to review. So you will learn a lot of things as well on updates that happened last year, but you've had more added to it this year. So please, please, please don't sit down and ever say to yourself, oh, it's January 2024 to August this year. The GPhC has already written those questions. So this is not going to come up in the exam because you're going to be shocked. All right. So the best thing you want to do is get yourself ready. Okay, so and you're going to see from when I go through some of these, again, as I said, it may be an update this year, but you will see that some of these updates on these drugs have been for the past years already. So let's go in. Number one. So we're going to start with January 2024. Let's see what updates happened in January 2024. So this is going back to, again, Ali just mentioned something about updates this year. GPhC exam is already written. So are they going to ask these questions? So here are the updates. We've had updates on valproate in January 2024. We've had updates on fluoroquinolones, antibiotics, such as your ciprofloxacins, and updates in January on omega-3 capsules. Now, sodium valproate, and this is going back to the question Ali just asked. Ali, this is going to make total sense to you now. Now, we've got sodium valproate, and as you know, sodium valproate is actually a high-risk drug. It is actually the last drug on the list of high-risk drugs. If you look at those list of groups of drugs, the very last one is sodium valproate or just valproate. So that tells you already that you're going to have at least one question. That's the GPhC's promise. You're going to have at least one question from the high risk drugs, okay? And one of those is valproate. So yes, you could have an update that is 2024, but that doesn't mean they're not going to test you on this drug, right? So please be aware of this. So we're going to go through valproate, the changes that have happened. And the reason why I'm going to take some more time on valproate, because I think this is one drug that it's not only a high-risk drug, which means it has a very high chance of at least one question being assessed in your exam from valproate. But also in the past years, there's always been updates on valproate. And the GPhC loves this drug constantly. If you go onto the LinkedIn for a long time, maybe it's a bit calmer now, but for a long time, the GPhC, almost every other post last year or the year before was on sodium valproate. So we've had changes in the last year, every single year, pretty much on sodium valproate. So we're going to go through the journey so that you could see all the important things you need to know when it comes to MHRA updates with valproate. Then we're going to go through fluoroquinolones. Again, these are antibiotics where you're going to see that there is an update this year, but some of these updates were already there. All that's happened is that we've literally placed more emphasis on some of them. And then we're going to look at omega-3. So let's start with sodium valproate. So what I've done is try to make it really, really easy for you. And I happen to put together a nice little diagram. So this is a bit like a flow chart you could see from 2014. So I just want to show you the journey of sodium valproate, just to show you how important this drug is, not only for your exam, but also as a pharmacist. Let me take this comment out. Okay. Also as a pharmacist. So we're going to start with 2014. So almost every year you've had updates on sodium valproate. So in 2014, the first thing which most of you probably know is it was found out that this drug with studies showed that they cause neurodevelopmental delays in children. This is a reason why the contraindicated, or you don't give it to any females of childbearing age unless part of the pregnancy prevention program or there isn't any other alternative. So the first thing you need to know is this drug could cause neurodevelopmental delays in kids, in children. And when we talk about neurodevelopmental delays, what do we mean? We're looking at mainly things like, like your autistic type of symptoms. So, and also some of the structural congenital ones, such as spina bifida. These are some things we're looking at. Severe situations, cleft palates. In terms of development, you're looking at some of the autistic spectrum symptoms, like maybe movement, speech delays, movement, and this sort of symptoms. So it's very important. That's 2014. Another important interaction, an MHRA interaction with sodium valproate, which was in 2014, was the interaction with carbapenems. So with your carbapenems, such as your meropenems, these are broad spectrum antibiotics. And the interaction between these two is carbapenems reduce the concentration of sodium valproate. So this means anyone that is prescribed a carbapenem antibiotic with sodium valproate, that's going to reduce the concentration of sodium valproate. So it increases the chances of the patient getting a seizure. This is a very severe and very, very, very important interaction. So how do you apply this in practice? As pharmacists, what do you need to know? If a patient has been prescribed a carbapenem and that patient is, say, epileptic on sodium valproate, you have to refer that prescription back to the GP to change that to an alternative antibiotic. So please learn this interaction. It is important. Then again, 2014, we found out this drug, and this is normally when you use sodium valproate long-term. So if you're using it long-term, then there's a higher risk of you getting osteoporosis and fractures. So again, patients that take sodium valproate for a long time, you tend to encourage them to supplement with some vitamin D. And that is just to prevent the risk of osteoporosis, the risk of fractures. Another thing I'm going to mention as well, which you need to know, because in your exam and generally as pharmacists, it's not enough to just know what a side effect. You also need to know what to do in order to resolve that issue. And the GPs will love to test you about what to do when things go wrong, or what to do in a situation where, for instance, a patient is taking this medication and they're experiencing some osteoporosis. It wouldn't come up as osteoporosis. They might have fractures, weak bones. What it basically does is takes away all this mineral. So it decreases the mineral bone density. And so that makes you higher risk of having fractures, especially elderly patients. So another thing you need to know. Now we've moved from 2014 to 2016. Again, abnormal pregnancy outcomes. So again, the same thing I was talking about, the sort of abnormal outcomes we're looking at is when females or ladies of childbearing age are on sodium valproate, they have these outcomes. And these abnormal outcomes, about 10% are what we call congenital outcomes. And congenital outcomes, again, cleft palate, Down syndrome, spina bifida. These are congenital ones. But then you also get the developmental ones, which are normally about 30 to 40% of side effects, development side effects in the child. And these are when you see all of those autistic spectrum symptoms. So again, slow speech, walking issues, poor language skills, memory challenges. All of these are what you will get if a lady was pregnant and she took sodium valproate, especially for quite throughout the pregnancy. So that was obviously 2016, and then we came to 2018. And the new thing 2018 was again an implementation of what we call a PPP. So basically what happened is there was still many risks with these drugs. There was still not enough counseling. There was still not enough awareness about the risk, the 30 to 40% teratogenicity of this drug. So what they decided to do was implement what we call a PPP, which is a pregnancy prevention program, which simply means any woman or any lady of childbearing age that takes this medication, sodium valproate, should be part of a PPP. And so what is the PPP? Does anyone know? What is it? When we talk about pregnancy prevention program, what do we mean? Can you tell me what that is? What is the pregnancy prevention program? What is it? Just type in the comments if you know what is the pregnancy prevention program. Because it's a bit of a fancy word, a fancy name, pregnancy prevention program. But what exactly, and you're required to know this, what exactly is the pregnancy prevention program? When we say that, what do you refer to? So great. Let's see answers. Well, Blessed says highly effective contraception. Correct. Those are one of the things. So as pharmacists, we need to make sure that if there's any patient that is on sodium valproate, a female of childbearing age, we need to make sure that they're aware that they need to be using a highly effective contraception. That's the first thing. And the highly effective ones are exactly as Eva has put down, correct? Things like your IUD, right? Or your progestogen only type of contraceptions. But your IUDs, very effective. Great. So what else when we talk about the PPP? What else are we referring to? So please learn what this is. Learn what when we talk about pharmacy prevention program. So other things we're looking at is when you have a patient, you have to ensure that that patient has seen the specialist. Okay, so they have the specialist reviews, and I think some patients need to have a review twice a year, but make sure they've at least had it once. They've seen the reviews, the specialist. So you've got specialist reviews. Make sure they've got patient cards, the guides. They're going to have some sort of form with the specialist to just show that they need to sign this form. It's a consent form, just simply saying you're aware of the risk of the medication. Right, so very, very important to know what the pregnancy prevention program is. So it's just a program that's there to just make sure you're giving them enough information and everything is in place to make sure that there is no risk of this patient becoming pregnant. And if the patient is becoming pregnant, they know exactly about the risk this drug poses. Annual risk review, yes. Fantastic, great stuff. So that's the PPP, and that was introduced in 2018. And then we came to 2023, which is a year ago. So Ali, do you see what I mean? Ali, give me a yes if you see what I mean. So although we're talking about an update of this year, you can see that we've looked at different things from the previous years, which could potentially be tested in your exam. And sodium valproate, the reason why we're going through sodium valproate, again, it's a high-risk drug. And the GPS has really promised to you that your high-risk drugs, you have at least one question in your exam from your high-risk drugs. A very, very high chance you're going to have a question 1 or 2 from sodium valproate. Okay, great stuff. So then we come to 2023, which is just last year. And what they discovered is all these years we've been talking about women, childbearing age. We're looking at the congenital effects this can have, the neurodevelopmental effects this can have on the baby. We are looking at making sure that pregnant ladies on this medication have folic acid. So it's always been a focus on women and the effects of the drug on the mother. But recently, last year, well, they did a study, and the study I don't think it's still conclusive because you need more studies to be done. But then the study also found out that a father or a man, and in this study, they took fathers that had taken the medication for about 3 months before conception. So 3 months before conception, they've been taking sodium valproate, and what was discovered is there was a risk on the children with dads that were on sodium valproate at least 3 months before conception. So the risk again is still the neurodevelopmental issues. So if a man is epileptic and he's taking sodium valproate, if he has sexual intercourse and lady becomes pregnant, then that child has a risk of developing neurodevelopmental problems, just like it is for the mom as well. So because of that, we then moved on to implement new strategies, knowing that sodium valproate, we avoid sodium valproate in both men and women below 55 now. So it's not just about women of childbearing age, but men as well that are less than 55. Evelyn says valproate did come up in the June exam, and it comes up in almost every exam. So just to give you a little tip, on your high-risk drugs, on that list, you have you have drugs, individual drugs, and you have groups. So a group could be corticosteroids, that's a group. Opioids, that's a group. But then you have individual drugs, and anytime you see an individual drug, you need to put in a lot of emphasis, a lot of learning, master everything on that drug, because they tend to ask those questions in the exam. So an example is sodium valproate is the last on the list of high-risk drugs on your GPhC framework. Another drug is methotrexate, high risk. Always comes up in exams, is because these are high-risk drugs, individual drugs. Another one, insulins. So please remember that this is probably one of the most important MHRA updates that you absolutely need to learn. And I have a very strong feeling you will see questions on sodium valproate in your exam in November and in June next year as well. So the next thing then, which again was last year, was that introduction of full pack dispensing. And again, the reason why this was introduced was because the MHRA felt that there were still a lot of patients that were not receiving leaflets, were not receiving enough information about the risk of this drug on pregnant ladies or women of childbearing age. So in order to prevent that risk, what they decided to do is to make sure that this is dispensed in the original manufacturer's pack, because the pack has the labels in there, it has the warnings, and so it's the only way that we can guarantee that the patient is aware of the risk of sodium valproate. So you have to dispense this as full packs, not split packs, and you could round up or round down and make sure it's close to what's dispensed. Okay, so if you have a pack of 30 and your prescription says 28, you have to dispense 30. Okay, so again, that was last year. And then finally, this year is what I mentioned earlier. So this year, the update was we need to now avoid this in both men and women that are less than 35. And the only time you would give sodium valproate to a man or a woman that is less than 55 is when you've had two specialists independently confirm that there isn't any other safe option, and so the only option for this patient is to prescribe them sodium valproate. When you have two independent specialists confirming there is nothing else, this is the only option, that's when you would tend to see that prescription given to a man or a woman that's less than 55. Is this clear? Type of 1, type of 1, type of 1. So please just learn this. I decided to give you this journey because I know how important this medication is, not only for your exam, but as healthcare professionals. Okay, so let's go to the next one. So the next one is omega, right? So what do we use this omega for? What's it for, omega-3? What do you use it for? Because some of you probably dispense this in your pharmacy. Sometimes people buy this over the counter. What is it used for, omega-3? What is it used for? So omega-3, it's normally used to reduce the amount of cholesterol around your heart, which means it reduces the risk of cardiovascular diseases or cardiovascular events just by reducing the plaque, cholesterol. But with this specific medication, it's dose dependent, which means it's not necessarily just omega-3, but it is a certain dose of omega-3 that's the issue. And also patients that already have a cardiovascular disease. So the patient may have had a history of stroke. The patient may have angina, for example, or a risk such as hypertension. That's when we need to be very careful with this warning. So omega-3, if you give this to a patient that, number one, has got a cardiovascular disease or a risk, if you give them omega-3, you have to look at the dose you're giving to them. Generally, when they did the study, they found out that it's normally anything that is above 1 milligram. That's when the risk starts increasing. And it's the risk of them getting atrial fibrillation. So you take this, if you take like 4 milligrams or 4 grams a day, which is 4,000 milligrams. So we take 4 grams a day, then very, very high risk that that patient is going to get atrial fibrillation, which could in turn lead to a stroke. So that's what you're looking at. So that's why if you look at the pack, and most of the packs that you sell in the pharmacy, they're mostly 1 gram. 1 gram, 1 capsule a day, 1 gram, 1,000 milligrams. 1. Anything above 1, you're increasing the risk, especially if that patient has got a cardiovascular disease. So it's just worth being aware of this. Someone comes to your pharmacy and they're coming to buy omega-3, then you need to definitely look at the dose. Majority of the time, it's normally 1,000 milligrams that we sell. You just have to tell them, don't take 2 capsules. And if you experience any signs of atrial fibrillation, what are you going to tell them? What are the signs of atrial fibrillation? What sort of symptoms would you expect if a patient came to the pharmacy, they bought omega-3? What are the symptoms that are going to trigger as red flags for you? What will they tell you that will make you think, oh, we need to be cautious here? It could be the patient experiencing signs of atrial fibrillation. Yeah, so you're looking at an increased heart rate, right? Heart palpitations, some shortness of breath, racing pulse. So all signs of atrial fibrillation. Again, worth learning this just in case this comes up in your exam. So yes, shortness of breath, palpitations, dizziness, tiredness, all of these are signs of AF, and that's what you need to look out for. So now we go on to February 2024. So in February 2024, the two main MHRA updates. Number one is your coding linkers. And I'm very glad that finally, the MHRA changed the classification or reclassified coding linkers from a P to a POM, because the amount of abuse was insane. Sorry, the previous slide, it said 100 milligram. No, it's 1,000. Oh, sorry. Oh, yes. Oh, it comes as 1,000 milligrams. Yeah, I meant 1,000. So 1 gram, sorry. Or do you have 100 milligram capsules of this? I think the mini come as 1,000. Yeah, so that's meant to be 1,000 milligrams. I'll just double check that's meant. But the main thing to take away is you shouldn't go up to 4 grams, which is 4,000 milligrams a day. But yes, I'll double check this. That's meant to be 1,000 milligrams. Thanks, Evelyn, for spotting that. You got good eyes. It's good to see you very attentive. I love it. Okay, so yes, so 1,000. Or do they come as 100 or 1,000? Let me know, because as far as I know, they come as 1,000. Perhaps there might be 100 milligram caps out there. That was just the brand. Okay, that's just the brand name. So I need to check whether they come as 100. No, I think they come as 1,000 milligrams. Probably just an error. Okay, so let's look at February 2024. So coding linctors, I'll tell you a story, and I bet some of you might have had this in your pharmacy. I had one specific patient in the pharmacy, and my pharmacy had about 4 different pharmacies in the region. So you had like Lloyd's Pharmacy, you had Sainsbury's, you had my pharmacy. And I had this specific patient that used to buy coding linctors from all of these pharmacies every single day. They used to buy a bottle, so about 4 bottles every single day. And all they used to do is go into one pharmacy, buy coding linctors, go on to the next one. So obviously we identify this patient comes in all the time. So I had to obviously block them and ban them from buying anything in the pharmacy, but they used to play around with locums. And this patient used to take a lot of codeine, buy a lot. So what do they used to do? The codeine is converted to morphine. So when you take codeine linctors, it's converted by an enzyme in your body into morphine. So what these people were doing is they're taking all of these codeine linctors and they're mixing it up with other things, and that gives them a good buzz. No, we've not done fluoroquinolones yet. So that gives them a very good buzz. And then also it was pushed over on social media. I don't know if any of you have heard of Purple Sprite. Oh, no, Dirty Sprite. They call it Dirty Sprite. Anyone that's into hip hop and R&B, a lot of rappers mix this in a bottle. It looks purple, and they call it like lean. Yeah, that's the name. They call it lean. And on social media, because all of these rappers and all these celebrities are promoting coding linctors and the effects it has and the great effects, you perform better, you chill. It's just taking morphine and the effects. So because social media, this whole purple drink just grew massively, right? So it became so popular. And so a lot of many people were buying coding linctors. So because of that, there's been a significant abuse and addiction and then dependence. What are some of the side effects you can get from an opioid overdose? Remember, opioids are high-risk drugs. Always come up in your exam, right? So you will get at least 1 or 2 questions on opioids. It could be codeine, we never know. But what sort of side effects would you get for someone that is taking an overdose of codeine linctors? What sort of side effects will you get? Shortness of breath, fantastic. Tokyo, yes. So respiratory depression. Pupil constrictions, correct. But we're really concerned about that respiratory depression. And imagine most of these people that abused it, they didn't really take it according to the dose. They mixed it up in bottles and they're just going to keep and just drink it. So that's why it's so important that now you know that it has to be prescribed only on prescription. And coding linctors is only used for chronic cough. And most of the time it's recommended that you only take it when you've had a cough for more than 8 weeks. So that long, more than 2 months. If you had a cough for more than 2 months, that's when you should be taking coding linctors. If not, you shouldn't. So that's what coding linctors is now a POM from a P. And then another one is pseudoephedrine. And with the pseudoephedrine, again, we have a lot of medications we sell over the counter, especially your cold and flu remedies, your decongestants that contain pseudoephedrine. So I'm very sure that they will give you some sort of questions on this. If not this year, perhaps next year, because you have things over the counter that could lead to what we're about to look at here. So with sodium pseudoephedrine, there's this rare risk. So it's not a common risk. It's not something that you'll probably see or witness, but it is rare. But there is a risk that patients that are on pseudoephedrine, they could have some reversible encephalopathy, right? So encephalopathy, do you guys know what some of the symptoms are? What are the symptoms? So how would someone came to your pharmacy and they came and bought some Lemsip, for example, right? So they got some Lemsip and they came back to your pharmacy a few days later with some symptoms and a bit worried. What sort of symptoms will make you think, oh, this could be reversible encephalopathy? What sort of symptoms? They should do the same thing with cocodamol and Nurofen Plus. I agree. Yes, I totally agree with you on that one. They should. I'm sure they will eventually. What are we looking at? Yeah, so we're looking at mostly headaches. So they could give you in the exam, it could just be a scenario question. One of those questions, a patient comes in, OTC, they've bought something over the counter, or if they have a history of hypertension, you don't want to sell them pseudoephedrine, or if they have any sort of kidney issues, right? So kidney issues, any history of hypertension, because some of the symptoms you're going to get is exactly what Bless has put down. You're looking at things like headaches. You're looking at things like confusion, yes, loss of memory. These are all cognitive sort of symptoms. Nausea, correct? So it's just worth knowing. So please don't just learn conditions by the name. Also learn how the conditions present themselves, because that's what the GPhC loves to test you on. So the symptoms. Okay, great stuff. So that's 2024. In March, there wasn't any significant MHRA update. So we're fine for March. So we're going to go into April. April was interesting. Reason why April is interesting, again, I'm going to go back to Ali. So Ali, this is an MHRA update of April 2024, but it's not a new update. It's not a new update. So the first one was finasteride, and just a reminder of the risk of psychiatric side effects and sexual side effects. So when anyone is on finasteride, especially 1 milligram, what is the 1 milligram used for? So you tend to find 1 milligram used for male pattern baldness. Propecia is the brand name. And then 5 milligrams is normally for BPH, benign prostatic hyperplasia. That's what you tend to see. Now, especially the 1 milligram tablets, what I found is patients that took these tablets to improve, to have more hair, ended up feeling suicidal, depressed. So anyone that's on this medication, you need to keep an eye on them and check on them, review, and ensure that they're not experiencing any of the psychiatric side effects. If they are, then they need to stop the medication. Another one that is highlighted more as well, not just psychiatric side effects, but also the effects it has on men sexually. So the sexual effects are things like sexual dysfunction, inability to get an erection, inability to maintain an erection. So sort of erectile dysfunctions are some of the risks that you get with finasteride. Then we had in 2024, montelukast as your chapter 3 respiratory system, your BNF. And it's the same thing. The reminder that with montelukast, you also have a risk of neuropsychiatric reactions. So only thing to take away from these is you just need to be alert with patients on these medications, or if the test, give you a test question, your exam on this medication, if a patient is depressed or that patient is already taking medications for some sort of psychiatric symptoms, then you don't want to give them finasteride. Okay, so then we're going to go to May 2024. Again, this is topical steroids. We've known about the different potencies for many years. But what they're going to do, what's being introduced, is a labeling that classifies the steroid according to its potency. So you're going to have hydrocortisone, but you're going to have a label on the hydrocortisone to say it's mild. So we'll have labels on there that either say a steroid is mild, or it's moderate, or it's potent. So as part of your exam, you need to know your different steroids, and you need to know your different potencies. For example, mild hydrocortisone is mild, clobetasone, Umovate is moderate, and then betamethasone is potent. And then you have a very potent, which is clobetasol. So what I've decided to do is so new labeling introducing to remind people of the possibility of very, very severe side effects. And you also get topical steroid withdrawal reactions. Do you guys know some examples? When we say withdrawal reactions from topical steroids, what do we mean? What do we mean by this? because that's the reason, because different steroids have different side effects, but most people in the public don't really know. So by grading them, by having the potency on the label of the steroid, that will help you, the pharmacist, to know what counseling to give. And that will also help the patient to know about the extent of side effects to expect from the steroid. So someone that is taking clobetasol, which is very potent, will then be aware that they may experience very strong or stronger topical steroid withdrawal reactions. So withdrawal reactions are things like stinging, the skin redness, so it's burning, right? So you have the steroid is so strong that it burns your skin, or you have redness or stinging. So these are the sort of, this is what we mean by topical steroid withdrawal reactions. So that was May 2024. Then we come to June 2024. So in June, going back again, I keep mentioning Ali. Ali, I bet you're like, gosh, Marvin keeps saying my name. You're famous. You're very famous in this session, Ali, because you asked a very important question at the start. So anyone who missed Ali's question, Ali was asking me, because the GPhC writes the exam before, way before this came out. So since it's just from January 2024, I heard that the GPhC wrote the exam 6 months. I don't even know about these things. So Ali was really asking, is this going to come up in the exam? If the exam has been written already, will this come up? So, and I was just trying to explain that when you go through, you're going to see that, yes, they could ask these things because they're not totally new, as this is the first time we're discovering this. Sometimes it just places more emphasis. So these, some of the side effects, you guys have known of them already, like codeine linctus and respiratory depression and all of this. But all the MHRA has done is taken stricter measures on these medications. So topiramate, for example, we know all epileptic drugs are teratogenic. Topiramate, you need to be part of the PPP. So if you're going to prescribe this, the patient still has to be part of the PPP. So again, you need to avoid it with women, childbearing age, similar to sodium valproate. Then there were alerts about interaction between warfarin and tramadol. So does anyone know what's the interaction between warfarin and tramadol? Again, in your exam, interactions, I have a whole I have a site where I help a lot of trainees, and I try to show you the common things that get tested in the exam. And one of those are, you need to know your cautions, you need to know your side effects, you need to know your contraindications. Definitely learn your interactions. And if you guys are interested, I could do a session with you on just MHRA updates. I could do a session where we're going to go through questions, but we will go through the questions on MHRA updates because they're so important and they do tend to come up in exams. So that's why I'm asking you, please know this. If you don't know it, find out, learn, find out, oh, what are the most important interactions that I need to know? What are the most, and I have all of those for you. I have loads of them. Not loads like overwhelming, but it's going to help you because you know the main ones to focus on. Okay. Yes. So someone has put what we got for the interaction. Evelyn, well done. Pharmacist, thank you. Bless, thank you for your interaction. Muna, thank you so much. Yes, increase iron, so it just increases the anticoagulant effect. And that is definitely a potential question that could come up in your exam. When I show you the predictions of things that tend to come up, one of the areas under the cardiovascular system are your anticoagulants. And we're looking at mainly DOACs or warfarin. Almost every exam, you're always going to have questions on anticoagulants without a doubt. And sometimes those questions are on interactions. So this is a potential interaction that you want to learn, especially because it has an MHRA warning, which shows it is very, very important. So warfarin and tramadol, two common drugs that you dispense in the pharmacy. Tramadol is just going to increase the concentration of warfarin or the anticoagulant effect. So there's very high risk of bleeding if you combine these two together. Is that clear? Type of 1, type of 1, type of 1. That's clear, type of 1. You are up to date. We are smashing all the MHRA updates for you. Right, great. So again, to pyramid, just a reminder, part of the PPP, don't give it to women of childbearing age unless they were part of the pregnancy prevention program. And the good news is we have already discussed what the PPP is, just in case it comes up in your exam. All right, Epimax, who dispenses this in the pharmacy? Type of 1 if you do. No, type of 2. Type of 2 if you do. Epimax ointment. So the ointment, not just Epimax cream. Epimax ointment. Who dispenses this? Or who's dispensed this week? So if you've dispensed this, Ali, what is the MHRA warning on Epimax ointment? Let me know. What is the MHRA warning on with Epimax ointment? Another important one is used commonly: eczema, dry skin, Epimax. So it's to do with the eyes. And again, it's something that is pretty new. Maybe most people don't know about this. Yes, Ali, that's another important thing you need to know here. Which comes first? Does the cream come before the steroid, or does the steroid come after the cream? Important, use it before the steroid cream. Great, but this is what I wanted to see. So the new MHRA warning is that this shouldn't come in contact with the eyes, the ointment. And the reason is because it causes what we call ocular chemical injury. And so it's really painful. So if someone is on Epimax ointment, you definitely tell them, don't rub this on your face. Right? It's be used on the body, but don't rub it on your face. And it's very easy to be done. Because think about it, when someone has an ointment, you've got dry skin, you're going to use that ointment all over your body, right? All over your body. But if it comes in contact with the eyes, it can harm your eyes, right? So you don't want to use on the face. So the counseling you want to give the patients is use this all over your body, but please avoid the eyes, because what will happen if they rub it on the eyes, there's going to be swelling, there's going to be redness, there's going to be pain, there's going to be burning, all of these symptoms. So they want to avoid it. And then the common sort of label 15 that we know about this is just it's flammable. And that goes to all your ointments and most of your creams. Stay away from a flame, but I hope you're not going to be standing next to some flame at any time of your life. It's dangerous. Okay, so that's it for July for Epimax ointment. Nothing much to take away. It's quite easy. It's just avoid putting this on the face, on the eyes. And when August, was starting now, it's 1st of September. So you're totally up to date. You're now up to date. Yeah, it's for the ointment. The cream should be fine. It's for the ointment. So Epimax ointment and paraffin-free ointment. Mostada. Yes, it's for the ointment. That's what the warning is, not the cream. Okay, so as you guys can see, you're now up to date. So we've gone through, just show you what we've been through. We smashed the whole MHRA updates from the 1st of January all the way to August. I have videos on YouTube with the previous MHRA updates, 2023 to 2024, and I have 2022 to 2023. So every year I do this. The next thing I'm going to do for you is I'm going to give you all the BNF updates. I'll just waiting for the new BNF to come out, but I'll give you all the BNF updates throughout the year from the 1st of January all the way. So you're aware, and so anything comes up in your exam, you are ready. So before we finish, do you guys want me to give you a little quiz on MHRA updates? So we could look at some of the past ones, right? So maybe from last year. Do you guys want me to give you a little quiz? Type a yes if you do. And I could just ask you the questions and I can answer from you. Do you guys want a little test? You want me to test you about the most important things? I have all of this stuff. All of this stuff as part of my BNF club. Okay, so I'm getting yes. Marvin, you mentioned a further session about the MHRA session updates, but where can we find all the previous updates that might come up in the exam? All right, so on the MHRA website, you have all the updates. If you wanted like a video with my explanations on the Preregshorcuts course, I have updates on every lecture, but I also have these videos on our YouTube channel. all you have to type in is just probably Preregshorcuts MHRA updates or Marvin, and you'll see those videos. And you can see the video I did last year with all the updates and the year before. Let me see if I could even find it for you. 1 second. Perhaps I'm able to. Maybe not. Yes, but if you want that, it's on the website. It's on YouTube. It's free on YouTube. Okay, so let me give you some questions. I have a website that has all these questions. I put everything together, the most common things that come up in your exam. So let me ask you some questions from there. In fact, what I'm going to do to make it easy is I'll see if I can copy and paste. I'll see if I can copy and paste. Okay, so this is the first one. And this comes up in the exam quite a lot. So let's do a little test with your MHRA knowledge, see how good you are. And Ali, you'll be pleased to know that we're going now previous years of MHRA warnings. So yes, this will come up in your exam. All right, so that's the first one, and I'm going to bring that up for you guys to see. So it's like question number 1. What are the key concerns associated with closer pain? Those of you on my course, you always know me. I always talk about closer pain, close the door. And closer pain is one of those drugs that tends to come up quite a lot in your exam, and you need to know all your MHRA warnings when it comes to closer pain. So what is it? Let's see what we have. An open session, active recall. Whatever comes to your brain, just spit it out. These are going to be MHRA update questions from the past years. So low white blood cells, fantastic. Granulocytosis, neutropenia, correct. Big tick there for you. Tokyo in the house, neutropenia, Eva, well done. A big one, a big one. So what else? I'm getting a lot of blood disorders. That's correct. What else do we have? Paralytic ileus. Very good. How does it present itself? An intestinal obstruction. Evelyn, what does that mean in terms of symptoms? What am I going to see? What am I going to see? It should be used after 2 antipsychotics. Yes, and I think one of them should be, it should be 2, but one of them must be a new generation. Constipation, thank you very much. Thank you, constipation, fantastic. And these have come up in the exam a few times, so please learn everything inside out when it comes to closer pain. We've got smoking. What is it about smoking? Is it just smoking? What do we say about smoking? So just with smoking, if you stop smoking, increases the concentration of closer pain, right? Because smoking is an inducer. So if you stop it, or maybe you switch to e-cigarettes, then you have to adjust that dose because it's just going to go up and you could get toxicity. Great, great, good answers, good answers. Please learn this one because this definitely is important. So I'm going to put an answer there for you, what I have as an answer, and it's the way I answer this question. So that's my answer for you. Just worth knowing. Click a screenshot, just learn that. Okay, so one of the MHRA warnings, they're a very common one that comes up a lot in the exam. It repeats itself. So the next one I want to ask you is another MHRA warning question. That's all we're going to do. And it's this one. What about this? What potential risk does quinine have as per MHRA? And by the way, if you don't know, please put a 0. It's just going to help me to know how much to give you. Gufran Abbas, that's correct. And that's why we say close the door, close the pin as the last option. Again, after you've already tried 2 of those antipsychotics. Thank you, Nima, for putting a 0. It just helps me to know how much to explain, because sometimes you just do things. I think, okay, everyone knows this, but I'd rather take time to make sure that you guys get something out of here, because that's why you're here, and I respect you and I want you to benefit. Okay, so I've got 0s. That's thanks for putting that down. So I've got tendinitis and 0, 0, 0. Okay. For those of you putting 0, I'm going to help you. So next time, if this comes up in your exam, you're ready, right? So think about QT, QT interval. QT interval prolongation with quinine. So it helps because it's got a Q, right? So although it's dose dependent, so the risk is dose dependent. It depends on the dose of quinine. But what you should know to make it easy, if you get a question in the exam, and this is not this year, it's come a few years ago, on quinine, is quinine can cause QT interval prolongation. And you need to know the drugs that cause QT interval prolongation. Does anyone have any other example? By the way, I just noticed that I missed, when I was explaining stuff to you guys, I think I missed the quinolone, didn't I? I had it at the first slide, but I didn't go through it. Fluoroquinolones. I didn't go through this. I think someone asked me, and I didn't get that at the time. So, oh, Marvin, have you covered fluoroquinolones? And I didn't. But with fluoroquinolones, I don't know why I probably left that out in the notes. I should have had that. How did I forget that? So I just had it on there. But yes, fluoroquinolones, the main thing with fluoroquinolones is they use as last option antibiotics now. We've exhausted all of the options, and that's simply because of the risk that they have on the heart. They also cause QT interval prolongation. And so your fluoroquinolones now should be used as last option when you've exhausted other antibiotics. Definitely worth learning that. Last treatment in line infections, yes. Your quinolones. Too many risks. And all the other side effects which get tested in your exam with your quinolones. Increase your risk of seizures when you have them with NSAIDs, tendinitis, all of that. Okay, great. Let's look at another MHRA question. I've got loads. I've got almost 60 of these. We're not going to go through all 60. I'm just giving the ones that come up in the exam. That's so important. And then I'll let you enjoy your evening. Okay, this is another one. And it is one that you have to know has come up a few times in your exam as well. Ali, I need them all. Ali, when are you sitting the exam? When are you doing your exam? QT interval prolongation, fantastic, with your macrolides. Yes, just like your quinolones, but that's certainly one they expect you to know, because macrolides, antibiotics are high risk drugs, so you need to learn all of this. Oh, Ali, you're doing in November, okay. If you send me a message, I can show you a few things that will help you. Let me see, I may even be able to share this with you, my screen, if I can. Okay. I'll share my screen with you, show you guys what I'm using. So I have, I've got this sort of platform, and this is what I was talking about. And what I've literally done is I have every single important area that gets tested in your exam. Now you have to see that there's only 3 steps to learn. The easiest is what we call quizzing. You quiz yourself, you use active recall notes, and then you test yourself with GPhC-style questions. So it's very simple, 3 steps formula to success. Use this with so many trainees. It works like crazy, okay? And so my whole learning strategy is based on these 3 steps. So anytime you want to study, I'll give an example. Ali, I'll show an example. So I have everything broken down per your chapter of the BNF. So you got cardiovascular infections, nervous system, all of this. So say, for instance, you wanted to learn cardiovascular system. You wouldn't just go and start reading notes. What you would do is step 1, you start with quizzing yourself. You quiz yourself to see how much you can recall actively, and then you go on to start learning. And then at the end of that learning, you then test yourself with loads of GPhC-style questions. So if I wanted to learn, say, cardiovascular system, the way I learn, and I could learn with you guys, if you want to see my strategy, is I will go to cardiovascular quiz, and I'm going to start off from here. So I'll just go, okay, I'm going to do nitrates. Let's click on nitrates, and I start answering this question straight away. See how much I can remember on nitrates. So we're going to go. And these are just the key things that get tested the most. So it's literally like selecting all this overwhelm and really focusing you on the areas that are the most important. That when you learn them, and it's so easy to learn them this way, it's fun as well. And you can do so much without being stressed. And it's just a very good way of learning. So I'm going to go nitrates, and I'm going to just answer these questions. I'll see what I can remember. Name 1 short-acting nitrate. Right, you got to think, what's an example of short-acting nitrate? Sublingual glycerin trinitrate. Right, your GTN most popular. Name 1 long-acting isosobide mononitrate or dinitrate, MRs. Then next thing is the counseling. For standard release oral, how should the second dose be timed? So your timing of the dose is important as well for nitrates. So you know about tolerance, you take it 8 hours instead of 12 hours. So if you have a nitrate that you take twice a day, Second dose is taken 8 hours later, not 12 hours later. Name 2 side effects of nitrates. You need to know your nitrates. That's what's important. The side effects, things like flushing, dizziness, headaches, side effects. It's so simple, but these are key areas that get tested if they're going to test your nitrates. Which drug interaction with nitrates can precipitate severe hypotension? The common one comes up in your exam is normally to do with drugs like your sildenafils, right? They'll test you on a patient comes to the pharmacy, they'll give the patient's PMR, the patient takes a nitrate, and the patient is coming to buy some Viagra. So what is the interaction? So it's severe hypotension. Then you have how should you use GTN spray? So if someone is having an attack, an angina attack, so 1 to 2 sprays under the tongue is sublingual. So you need to know in terms of counseling how to take it under the tongue. Now, what do you do? It's so important is what you do. So they obviously take the first spray, the 1 to 2 sprays. If that doesn't relieve the chest pain after 5 minutes, you do it again, another 1 to 2 sprays. If that doesn't release the angina pain after 5 minutes, then you dial 999. Okay. And then also in terms of dispensing and the storage of nitrates, you need to know that information. Okay. When do you discard it? Once you've opened the bottle, is 8 weeks later. Right. And then the rest of the things about having a dark bottle, no light going through, cotton wool wadding, and maximum of 100 in a bottle. And these are direct. So that's literally what you learn with nitrates, and that already gives you a good foundation. Then you move from here. If you wanted to enhance even more knowledge on nitrates, then you're going to move on to your active recall notes. So these are the proper notes that I have, active recall notes. But then I'll go to proper notes to then read more about nitrates if you wanted to. But just doing this already gives you a good platform, because this is the basic knowledge that most people know. And when you get tested in the exam, it will come from here. So if you test in the exam, it could be something on dosing of your nitrates. It could be something on tolerance. It could be something talking about how to take it sublingually, which we've just looked at. It could be a question with nitrates on interactions, especially that your sildenafils. It could be a question again on how to take it, like first time 5 minutes, nothing. What do? You take 1 to 2 again after 5 minutes. If there's no reaction, then you call 999. Or it could be about the storage of nitrates in the bottle. So that's how easy it is. And that's like, I'm done with nitrates, and I'm like, fine, that's good. Go through my notes and I do some GPhC-style questions. Any sort of style questions that have come up in the exam with nitrates, I then try to answer those. I do the same thing with the next drug. I go for amiodarone, and then I just go through the questions with amiodarone. Okay, so it's the same thing. You just go through, name common substance that interacts with amiodarone. I've got a few of them. You need to know about interactions. What are the pulmonary adverse effects associated with amiodarone? Boom. What type of thyroid dysfunction do you get amiodarone? Hypothyroidism, hyperthyroidism. Next thing, name some of the adverse side effects. Try to think about it without looking at the answers, and then you look at the answers. So that's how you study, and it's so engaging. It's so easy. It's so interactive. You can do so much as opposed to having loads of notes and sitting down in your bedroom and thinking, gosh, am I going to go through all of this? And I'm bored, I'm tired. So I have, this is the whole of the cardiovascular system. And it's key areas. It's not just the whole of the chapter, but key, most important areas that get tested. When you come to like my DOAC quiz, high rating, loads of questions again on DOACs. I have even more. So that's cardiovascular. You could see all of that. And then I move to infections. If I want to read the infections chapter, I'm not just going to start reading the whole of the BNF chapter 5. That's ridiculous. I'm just going to go through the 10 to ask you questions on trimethoprim or nitrofurantoin. In almost every exam, you have one of these drugs. So I've got very good quizzes on this, right? The counseling points, things to measure on there. So I'll do that. I'll do trimethoprim, the common questions that could come up on trimethoprim, all in there. Quiz yourself. Then you go to the rest, right? Amoxicillin, doxycycline, clarithromycin. For instance, we just looked at one of the macrolides. If you go in there, it shows the common things you need to know when it comes to macrolides. Clarithromycin, all on there for you. So it's easy. Right? It's easy to learn. It's interactive. It's colorful. And that's what you need to, that's how you need to learn. If not, it's just everything's too boring and too overwhelming. I've got on here 27 common bacterial conditions. You guys still see that? I've got 27 in your exam, the 27 common bacterial conditions that could be assessed and that tend to be assessed. There's just 27 of them. And if you go through all of them, you're fine because it's guaranteed you have 1 or 2 or 3 in your exam. So I actually go through all 27 here with exactly what you need in terms of the treatment. So you can see the first one is mastitis. It's come up in the exam a few times. What is the first line treatment for mastitis? Boom, what is the dose? Right? Fluclox, what is the dose? 500 milligrams 4 times a day. Next thing, human and animal bites. What antibiotics are recommended for human and animal bites? Boom, what is the dose? On there. So it's just that straight. And if you look at any past papers or speak to anyone that sat the GPhC exam and they've had questions on infections, which you always have, they're mostly on one of these conditions. It's either going to be mastitis, or it's an insect bite, or a human bite, or it's a fungal nail infection, or some chicken pox or chlamydia, or it's a sore throat, or it's a question on H. pylori, or it's cellulitis, all in there. So it's just having that confidence that everything you cover, if you do this well, you have no problems in the exam. Same thing with the nervous system. So I have done all the chapters, and then this is even another thing I've done. When I come to this, I have a whole separate section just on high-risk drugs. And the reason why I have it just on high-risk drugs is because in your GPhC framework, and you guys all know, in your GPhC framework, it says you're going to have at least 1 question from your high-risk drug areas. Right? You have at least 1 question from your high-risk drug areas. So because of that, I've literally put together all the high-risk drugs, and we have a quiz on all of them. So opioids, I have a quiz just on opioids, as you can see, quite a lot of questions. But yes, methadone questions, fentanyl questions, buprenorphine questions, morphine questions, codeine questions, tramadol questions. Yes, we have a whole list there, and that's all your opioids. But you know that if you go through this, you've already covered one of your high risks, which is guaranteed to come up in your exam. Sodium valproate, we just started doing sodium valproate. You see, I've got loads of questions there for sodium valproate. All right, so sodium valproate quiz or high risk. Then we have methotrexate, one that comes up in every exam without fail. Methotrexate, you need to learn it inside out. These are the notes. This everything on methotrexate. Just go through this and you're laughing. Questions, answers, question, answers. Separate one just on novel therapeutic index drugs like your carbamazepine, lithium, theophylline, phenytoin, everything for high risk. So you can just choose the high risk section and totally ace it, like really learn it inside out. Antibiotic quiz, a whole quiz, 50 questions just on antibiotics. Engaging, simple, very, very simple, straightforward. But yes, so that was just showing the strategy. And what we could do, I just asked you some questions. We could do some of these questions next time. I could go through some of this. If you, those of you that are doing the exam next year, Preregshorcuts, you know, we're starting the program tomorrow. If you want to enroll on the Preregshorcuts program, you could actually book a call with us on our website. You could go to the website, which is www.preregshorcuts.com. I'll put this in here. And in the chat, there's a chat. You can speak to one of our advisors if you want to enroll on the foundation year for 2024-2025. If you're sitting the exam in November, during November, and you want to get my quizzes and you want to join this, then please, you could send me an email. This, by the way, is a Calendly link for anyone that is doing the exam next year and they want to join the Preregshorcuts program. Then you can book a call and someone's going to call you and we could go through any questions you have about the program. Okay, so that's a Calendly link if you want to book a call. If not, you can just go to the website. It's an amazing program and you totally love it. Now, if you're doing exam in November and you want to join my BNF club, then all you have to do is send me an email on bnfcoach@gmail.com. And what I'm going to do is I'm going to give you access to this website and you could start trying some of those quizzes. right? So that's, if you're doing in November, then you want to email that bnfcoach@gmail.com. If you're doing it in next year, then it's Preregshorcuts. So with the quizzes, what we get with the quizzes, just to show you, is the quizzes. There's also some calculations as well, active, and then you have active recall notes. So I give you notes, I give you the quizzes, active recall, and then on top of that, I have live sessions with you as well. So you could see this number of live sessions coming up, like you got cardiovascular system exam predictions coming up soon, I think on Tuesday. So you have a whole list and the different dates of upcoming events, which are all the sessions. So every week I have a session. So there's infections exam predictions, there's nervous system predictions, there's endocrine system predictions, important GPhC topics. So every week there is something all the way to the exam. Powerful stuff, guys. So, and then, so it's me doing sessions with you. On top of that, you have access to all those quizzes. As you can see, there's loads of quizzes. I also give you a program, so you're not just going to learn the quizzes randomly. You have a plan to follow for 8 weeks. So that's why I have an 8-week revision timetable. And so I've organized all the quizzes in weeks for you so that you just jump in and just follow that and answer the questions and join the live classes. And then I will go through that with you. But again, this is just for those doing the exam in November. If you're doing the exam in next year and you want the foundation program, then that's Preregshorcuts. What is the website for this? The website is Marvin. So this is my website, marvinmunzo.circle.so. That's the website. That's the website with the quizzes. Okay. So I think I'm going to let you guys enjoy yourselves. With this website, if you wanted to, you could, if you send me an email, I could potentially give you a 24 hours access. If you wanted to, you could send me an email. I could give you a 24-hour access to the website. And then at least you can see if it's something you like. And take it from there. So if you're interested and you want to get like access to just see what it's like, I could sort that out for you. Someone's asking, what is the difference between the BNF Club and the Preregshorcuts clinical course? So the BNF Club, it's just quizzes and preparing. So most people will be on the Preregshorcuts course, and perhaps they've been through the course and they're still struggling. So if you're on any course at the moment, say you're on anything, maybe Preregshorcuts clinical, maybe you got clinical from somewhere else, Buttercups or whatever. If you're on a clinical course, and despite having the clinical notes and watching the clinical videos, you're still struggling with clinical, you're still not feeling as confident, and you want to boost your confidence, you want to do a lot of quizzes, then that's where the BNF Club comes in. And the BNF Club, it's all about quizzes, active recall, GPhC questions, and then with myself every week, motivating you, giving you structures, motivation, structures, direction, and that's the difference. And that's the main difference. It's all about quizzing. While the course itself is the whole course. So it's like the whole BNF. So think about BNF Club is like a subsection. It's like a summary of the BNF course Preregshorcuts. So we're not going to go through every single note, but we're going to go through just the most important. So our notes come like this. It's like you've read the course. I've gone through this course, Marvin. I've done Preregshorcuts clinical course. I've watched the videos, but I'm still struggling. I'm still finding it hard. I still just need that extra support. That's where the BNF Club comes in. So the BNF Club, you could pay in 2 installments, either $199 or $399. Okay, so the full price is $399. But you can pay in 2 installments, which is $199. So again, it's not something that is for everyone. It's just if you need it. Okay, I don't want you thinking, oh, I need to join this now. It's just only if you're still struggling. That's why I only work in a very small group. I can't have too many people. The groups with the BNF Club, I'm looking at, it's probably a maximum of like 15 to 20 because it's so personal. right? It's already so personal, and I'm giving my time, and I'm going to be working with you every week, and I'm going to be making your notes, and I'm going to be answering your questions. So it's me giving my time and making sure that I'm facilitating and just making sure it's easy for you. So maximum about 15 people, 20. It's always done well. At least with the private group, it's always done well. On the exam, people have always done well in it. But again, as I said, it's something that personally, I have it there for anyone that is still struggling with clinical, or that just wants that confidence. You want to walk in, you've got 8 weeks, and like, Marvin, I'm still worried, or perhaps it's your last attempt and you're scared and you want to do everything it takes to succeed. If that's you, this is an option. And I promise you 100%, when you join it, you'll be blown away because of how easy I make it for you. So when is this time for? No, it's for the November course. It started like literally starting this week. So if you're doing an exam in November and you want the BNF club, then you already have access to all of this. So most of it is already on there. So you have the videos, you have the quizzes that you can do already. But what happens is, as you can see on the upcoming events, it's actually starting. The first one will be on the 3rd of September. That's when I'm going to be going to the cardiovascular system. So someone's asking what's the difference with the Preregshorcuts course. The Preregshorcuts course, I'm actually teaching you the cardiovascular system, and that over weeks. So if you watch some of those videos on Preregshorcuts, the cardiovascular system is about 10 hours. The BNF club, we're not going through the whole cardiovascular system, teaching you every single thing like that. What we're doing instead is we're just focusing on the main areas that come up in the exam. So the BNF club is exam focus, if that makes sense. Preregshorcuts, we want you to be a good pharmacist, and you need to have that knowledge, and you need to learn about the whole topic. You need to learn everything. Like BNF is what this course, what could be tested, learn everything you need to know. BNF course is just for the exam. It's totally exam focused. It's literally, this is what's come up, this is what comes up regularly. These are the questions, let's practice. This is what's going to come up. The HAS formula, cardiovascular system, HAS formula, the 6 key areas that come up in the exam. That's the kind of tone that the BNF club has. It's exam, 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 purely exam focus, right? So the 6 key areas: cardiovascular system, HAS formula, hypertension, heart failure. We have short notes on these, short bullet point, bang, bang notes on heart failure, the common things you need to know on heart failure, common things you need to know on hypertension, A, anticoagulants, and the other A, arrhythmias, right? So short things on anticoagulants, on arrhythmias, quizzes, quizzes, quizzes. You don't have many quizzes like this in the Preregshorcuts, but you have a question bank. So you use both. You use both, then you'll be fine. So I use my formula. My formula is a 3-step process. It's the easiest that you can use in order to pass. It's just 3 steps. First step, as I said, step number 1 is quiz. Step number 2, active recall notes. So that's where you learn stuff if you wanted to. And then number 3 is GPhC style questions. That's it. No waste of time. This is the ultimate success formula. Anyone I've helped, and I've helped so many people succeed, is I've just used a 3-step process. We've gone into the quizzes, do the quiz. Anything you're not sure, you need to learn more, I've got the active recall notes. Enhance your knowledge if you're lacking on anything, and then let's practice some GPhC style questions. Once you do that, boom, 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 you'll be so amazed. Number 1, you have more energy. Number 2, you enjoy learning more. Number 3, you have someone like myself there to guide and support you, to give you that confidence and just be there to make you feel confident in yourself. And then number 4, it's fun, it's easy, it's all laid out for you. You have a timetable. You don't even need to stress anymore. All you have to do is like, okay, fine, I want to begin. This is what I need to do today. This is what I'm doing this week. Marvin has given me week number 1, week number 2, week number 3. Any issues, join the live session, ask me questions, and I'll be there to answer them. That's simple, guys. Okay, so I think I've taken a lot of your time. We started at 7:30 and now it's 8:46. I'll let you guys have a lovely evening. And I really, really know already that you all pass, because you're here today and you've shown me that you're really serious about doing this exam, about passing your exam. All you have to do is to believe in yourself and work hard. Have the best notes, have the best quizzes, If you have the best quizzes and you have the best notes with you, that's all you need. With practice questions, you have those three, the combination, you have the best quizzes, you have the best notes that easy to follow, make sense, and you have a number of GPhC style questions, you're ready to go, guys. It's easier than you think. Don't complicate the process. Enjoy the process. Okay, I'll let you guys know. Thank you all so much. Have a lovely week, and I look forward to seeing all of you soon. Take care, everyone. Bye.